particularly seen in young children with their developing dentition as their teeth are being pushed forward because the tongue is hyperactive and is taking more of an infantile type of position, and it is chronically pushing particular mandibular and maxillary incisor teeth forward. So there is this protrusion of the anterior segment of the maxilla or the mandible. Okay, so that's what some of the big deals are with things like tongue thrusting or oral habits or even thumb sucking. Is these are good instruments for moving teeth, but not necessarily munching where you want the teeth to be. Okay. Buccinator, if you do things like, this kind of fish-like thing with your, or if you do a lot of whistling, or you play some wind instruments and things like that, that chronic positioning that you do can move teeth. So, yes?
When you say neutral zone, is it neutral because the forces applied by?
Are relatively balanced,
Relatively
inside versus the outside.
Maxilla, mandible, and the tongue?
By basically the musculature attached to the maxilla and mandible, okay, and the tongue internally. But the tongue, by the way, is also attached to the mandible. All right, so if we look at the relationship of when we put our teeth together, and where are these forces generated? Well, some forces are generated forward towards the anterior section, but through the mandible, they are also generated to the maxilla, and from the maxilla up to the cranium. Okay, the maxilla up to the cranium. When normally on a regular basis our teeth together? When do we put our teeth together?
Intercrustation.
Okay. Should there be anything between them?
Not when you're not eating.
Not when you're eating, right? So, what do we do more than chew?
Sleep.
We swallow. What do we swallow? All of the saliva that's being produced in your oral cavity to allow these tissues to be moist and also to allow for the function of taste sensation to take place. Because taste receptors are chemoreceptors. Chemoreceptors have to be in a fluid medium in order to detect the tastes. Okay. So it's believed that on average, an average human swallows 1,200 times a day. If we ate that much, we wouldn't be able to get in that door. Okay, but we swallow 1,200 times a day. When we're chewing, food is typically between the dentition and is being ground up so that we can form it into what we call a bolus, so it's swallowable. Okay, but saliva is a liquid; it's always swallowable. But that helps to stabilize the mandible and other things inside. We'll talk about this more really in the end of the course about swallowing. But 1,200 times a day we swallow. That's a lot of times to bring the teeth up. Here is, these are called light casts, so a light bulb's been put inside the skull. And it shows relative density, in particular the mandible and maxilla are pretty dense. They're going to have to withstand significant forces, these forces possibly attaining 600 pounds per square inch. But these forces are being generated up to the skull. Now, this, I don't know how old the skull was at the time of death. This comes out of a textbook by a guy named Harry Seeker. But what he was trying to show is, see, here is the zygoma with its frontal process coming over here. And we're generating forces that are adjacent to the maxilla, and we're pushing them up here over the brow ridges. Typically the brow ridges are pretty thick as well. Now, what they have seen in skulls of aged individuals is that there are skulls that are less dense up here than most. And what is that from? That's from excessive forces that were generated from the jaws of this individual over the course of their life into the bone of their cranium. So chronic excessive forces of chewing are not a good thing, okay? They're not a good thing. Not only can they create destruction of the dentition or the bones that the dentition is within, but they can also lead to disturbances associated with things as high up as cranial bones, where there's an excessive thinning of cranial bones because of the chronic forces of chewing. All right, let's move on from bone and let's look at cartilage. Here we have this hard tissue here, which is, these are fibrocartilages. Fibrocartilages are cartilages that have to absorb the forces generated really at the condylar head in relationship to the mandible and the temporal bone. This is a diarthroidal joint, like some other diarthroidal joints in the body. Therefore, as part of its anatomical makeup, it has a synovial cavities inside here with this fluid that's being produced as a lubricant for joint articulation. Now, what we see here is not just this very large cartilage here that we call the articular disc or the articular cartilage, but there is also articular cartilage on the upper side of the underside of the temporal bone here, on the top of the glenoid fossa, and on the top of the condyle here. These are all fibrocartilages. This articular cartilage is actually tied down a couple ways. One, there's this articular capsule. This is an encapsulated diarthroidal joint, and the lateral medial poles of the capsule, this disc is attached, but also this comes out to the corners of the condylar head, the poles, the lateral and medial poles, and attaches there as well. So you can see over the course of time, in some individuals that are creating excessive forces, they may actually flatten and perforate this cartilage. Okay. Does it cause a problem for that individual? Well, it can. Does it cause pain? Well, it can, but not always. Okay. So individuals that we talk about this particular area, the temporomandibular joint area, we have to be very careful that we collect all of the data we need to make an accurate diagnosis of a problem that's possibly going on in this individual. And sometimes, in relationship to pain, sometimes it has nothing to do with this joint. It has to do with other factors associated with the nervous system or with soft tissue diseases or things like that, or even vascular diseases. So this is the articular disc sitting in here. We did a study on, it was a Sunday, 2 period on a Sunday, and we did a head and neck temporomandibular joint dissection. This is that particular cadaver. Here is the disc on its lateral side, see how thick it is, and here it is on its medial side. You can see how thin it is. So here we say this is kind of like a saddle when we look at it from this perspective, or we look at it here and underneath. They call it a meniscal cartilage because it looks like a meniscus that you would see in a column of water and a column of fluid with an indentation above and below, or a red blood cell. Okay, so this is the lateral side of this articular disc, and this is the medial side of this articular disc.
On that image,
Yes.
the medial, is that normal or is that just worn over time? So
That's
it's-
normal.
that's
It's
normal.
thinner. It's thinner over there. It's thinner over there because we have bone. We have this endoglenoid process that's preventing movement any further than the bone. Over here, we don't want to disarticulate the joint, so this actually thickening helps to hold the condyle in its mandibular fossa. And here, looking at it in a frontal section that we also have, we can see over here that we've got the cartilage on the top of the glenoid fossa. And this over here This is the superior joint space, or the superior portion of the temporomandibular capsule. Here is the articular disc here. And this is all all these cartilages are fibrocartilage sitting on top of the condyle. Being attached to the poles of the condylar head out here and here. And then we've got this inferior space here. And then we have cartilage on the top of the condylar head. So all of these are articular cartilages, or this is the disc. This is the superior cartilage. And this is the inferior cartilage. So when these bones come together, we don't have typically big spaces between joints. That's rather inefficient. That creates loose joints. They really don't move well. I guess unless you are a gymnast or a athlete that has developed all of this kind of increased flexibility over the course of your life and your training. But that's not necessarily a good thing over the life of you as an individual. Because you increase the mobility of joints that aren't necessarily best being more mobile. Okay? For example, some of the large joints in the body, like over here, the articulation of the femur or the acetabular space in the pelvis. Okay? But some individuals can do that and create interesting contortions of the body. However, you wouldn't see normally a space here, and you wouldn't normally see a space here. So you would have cartilage to cartilage to cartilage. You don't have cartilage to bone or bone to bone. Bone to bone is real bad, because when bones start to wear, they're like files. And as they rub against each other, they literally start to file away their opposing bone. So it could cause destruction. Can actually, you'll see in chronic destruction of this joint, you'll see patients that have worn the top of the condyle away, the head of the condyle. Okay. You'll see in some individuals, or they'll see this surgically, or they'll see this with a cone beam CT, that they have actually ground through the disc. They have ground holes in the disc. I think it was Dr. Kmet, I think this was your dad that did a huge study on this many years ago, where he looked in a cadaver population to see how many discs were perforated in these cadaver populations. But that's all we knew about it, was it perforated or not. We didn't know if that was causing, or he didn't know if that was causing any type of pain-related problem in this post-mortem individual or not. But there was a significant amount of disc perforation, which was, something that, was actually well read in the literature at that time, because we didn't know. That was one of the few control studies that was actually done up to that period of time. So here, looking at it from a lateral perspective, we see everything that in black is cartilage. So the cartilage on the articular eminence, the cartilage on the condylar head, and the cartilage on the articular disc. Here, down here, this is the inferior belly of the lateral pterygoid attaching to this pterygoid fovea in the neck of the mandibular condyle. All right, so to show you that this is kind of real, we also did our own dissection in here, and here we see this relationship between the cartilages of this temporomandibular joint. Okay, here's the external acoustic canal. So all of this bone surrounding it, that's tympanic portion of the temporal bone. But this is the tympanic membrane right here. So here is the articular eminence, and there is cartilage on the articular eminence. Here's the condylar head, and there's cartilage on the condylar head, and here's the articular disc. Now, there are two heads to the lateral pterygoid muscle. It is believed, although the inferior belly connects to the neck of the mandibular condyle, that this belly, the superior belly, attaches to the disc. Attaches to the disc. There's a lot of theories in relationship to why that happens, or why that has to be. Okay, so hard tissues are bones and cartilage. Okay. We go now. We've got ligaments. What's the role of ligaments? What do ligaments do?
Okay, with things like knees and shoulders especially, I mean, they start to wear out. You get replace that kind of thing. Is it very common to have that joint just wear out over time, where the cartilage just wears down and you get bone on bone, or is that relatively on?
It can happen, but it's probably
Knees
at a
is
low
probably-
percentage.
Okay.
At a low percentage. But what do ligaments do? What's the role of ligaments in the body? We're going to talk about them this afternoon.
Like bone to bone.
Bone to bone or organ to organ. They hold things together. In the case of bone or joints, they are there to try and maintain the integrity of the joint. Hold it together. Hold the bones together. Okay? So we have some ligaments associated with this temporomandibular joint. The capsular ligament. The capsular ligament has associated with it a very dense lateral band which is oblique. It comes from this articular tubercle and goes down to the back of the mandibular condylar neck. We'll see this. We'll see this in a couple of minutes. Okay? But there's also a band that is more horizontal that goes from the articular tubercle to the lateral condylar pole, to the outside pole of the cartilage. So this portion attaches from the articular tubercle to the condylar neck. This portion attaches from the articular tubercle to the lateral condylar pole. And then we have ligaments that actually attach the disc to the medial and lateral poles of the condyle, and they're called collateral. They attach the articular disc to the medial and lateral poles of the condyles. Okay. Then we have a ligament that goes from a little spine on the bottom, on the cranial base portion of the sphenoid bone that is adjacent to an opening through the base of the skull called the foramen spinosum. And this goes from the sphenoid spine to a little lip of bone near the mandibular foramen on the mandible called the mandibular lingula. Okay? And then we have a ligament that comes down from the styloid process and goes to the posterior surface of the angle of mandible. And then we have these. What do these do?
Hold the teeth in the socket.
Okay? What do they do from the standpoint of chewing? What information?
Shock absorbers.
What?
Shock
absorbers.
absorber.
Okay. What else? Okay. There are nerve endings in these ligaments that are basically proprioceptive. They are monitoring for the nervous system the force that's being put on the teeth, and also whether or not that tooth is moving inside of its alveolus. And that information is telling the nervous system how much force the muscles are generating during the process of chewing, and whether or not they're getting excessive forces or excessive forces that are moving the teeth within the confines of their alveolar sockets. If this goes on, sometimes the teeth all become sensitive. For example, if you did, what I said before, if you left a restoration high over the course of time, that particular tooth would suffer from the forces of chewing, and eventually it would start to move more within the socket and possibly be lost. So the nervous system, the body wants to know what's happening in every aspect of itself. So these proprioceptive fibers in these periodontal ligament spaces are important for giving that information in regards to the process of chewing. How do we know how much force muscles of mastication are exerting? Because of these receptors in the periodontal ligament space are telling it how much force is being generated on the dentition. Because that's what the muscles are about. Now when we look at these ligaments, what are these ligaments doing? Okay? Are they accentuating movement? Do ligaments accentuate movement in joints?
I don't understand the question.
Do ligaments cause joints to move more? Do they create movement?
Stability.
Stability. They limit movement.
Right.
They limit movement. So they're trying to hold that mandibular condor head in its capsule and provide an adequate yet not extreme range of motion. Okay? These ligaments are typically dense connective tissue, dense collagen. What happens when you stretch collagenous tissues, when you stretch ligaments?
There's.
Well, it might not turn, it might
Well,
just stretch, right? So you create hypermobility in the joint if they stretch. And that stretch won't go away. So once these are stretched, they're stretched forever. Okay?
So like in a boxer, you would have this kind of permanent looseness?
If he gets hit in the jawline,
Well, yeah, from the side, that's.
yeah, absolutely. Or anybody that walks into walls like, something like that, or, other types of external skull trauma, things like that. Okay. There is only one group of ligaments we'll talk about when we get into the neck that are elastic in their characteristic, and these are called ligamentum flava, and these are between the lamina of vertebrae, and they allow for recoil of the vertebrae, a subtle amount of stretch, so that the vertebrae can actually recoil to where they were prior to that point of stretch. But we're not talking about a lot of stretch, but we're talking about giving the vertebral column some ability to move. We don't have to worry about that right now. Okay, so let's look at this. This is the capsular ligament, this whole structure, and this ligament right here, portion of it, this lateral thick band from the tubercle down to the condylar neck, this is the lateral TMJ ligament, temporomandibular joint ligament. And it's going from front to back. So what kind of movement is it limiting?
Side to side.
There is a point, I shouldn't say that totally, there's a point that really the horizontal band comes in regards to achievement. But it's resisting downward and backward movement. Downward and backward movement. We want to hold the condyle as close to the mandibular fossa as we can. So we don't want it to move downward, okay? We can translate it forward, okay, but we're still holding it in contact with the bones, yes.
Can you draw an arrow, like what it's resisting? I don't think I understand. Right.
Move. Okay, it's just downward and backward movement. It's going from here to here. It's connected to bone on each side. All right, now here we have this sphenomandibular ligament. And it's coming from a more medial direction, a more forward direction. So it is actually coming from a position attached to the sphenoid spine to a position attached to the mandibular lingua. And it is more, starts out more medial and goes more lateral. So it is resisting downward and lateral movement. Downward and lateral movement. Okay, and here we see it again, coming from a more posterior to anterior, but also, but also from medial to lateral. The sphenomandibular ligament down here, attaching around the mandibular ligament. Then coming from the styloid process, the temporal bone, to the angle of the mandible, we have this ligament. This is the stylomandibular. And this is resisting downward and forward movement. So these are three basic ligaments. There are ligaments that are referred to as being collateral that are attaching the disc to the medial and lateral pole of the condyle. So the disc has to move with the condylar head. It moves in an interesting way. It actually has, there are two muscles that have a tendency bilaterally to move the mandible forward. Those are the pterygoids. But in particular, the lateral pterygoid has two heads. The inferior belly moves it downward and forward or unilaterally to the opposite side. We'll talk about that shortly. But the superior head keeps an attachment to the disc, and as the mandible moves, pulls the disc to keep it on top of the mandibular condyle. If things happen that cause excessive opening, the superior head can pull the disc off the surface of the mandibular condylar head and displace it. So here is a lateral TMJ ligament over here. Okay. Here's a masseter muscle in front of it. We actually, it's tagged with a string, so this was actually something we put on an exam. All right, so that we see in relationship to this lateral TMJ ligament. Okay, here we see this is the oblique band. And this is the horizontal band. The horizontal band goes from the tubercle over here back to the condylar pole over here. So this is the horizontal band of the lateral TMJ. Talk about that in a minute in relationship to certain types of mandibular movement. So this is helping in relationship to maintaining some stability of the mandibular condyle as the mandible is moving into a chewing posture. Okay. Well, how does the mandible move into a chewing posture? It moves from one side to the opposite side. Okay? And the side it moves away from is the balancing side. Okay? The side it moves towards is the chewing side. That is the side that we are engaging some type of food source and chewing it. Okay. So unilaterally, we'll talk about this shortly. Lateral lateral pterygoids, also medial pterygoids as well. They are the muscles that enhance the chewing movement. Okay, and they are muscles that together bilaterally can move the mandible downward and forward, or what we call translation of the mandibular condyle. Unilaterally, they move the mandible to the opposite side. So right moves to left, left moves to right. Now, there is this other philosophy, I don't know if Dr. J has talked to you yet about it, it's called side shift. So when we go into a chewing posture, okay, we are basically taking the muscle on this side and moving the mandible to the opposite side, okay? Now, this is not a round ball, okay? That's another thing that disturbed me a little bit with articulators. The condylar head and articulator, and some of the newer ones, it's more oblong, okay, or wider than it is anterior posteriorly. They have round balls as condyles. That's not what we have. We don't have round balls as condyles. Okay. So we have to move this condylar head that is wider medial-laterally than anterior-posteriorly, and depending upon how far a chewing stroke or how far we move it to the opposite side, we have to keep the condyle in the mandibular fossa. So the ligament, this temporomandibular joint ligament in particular, here is the oblique bands, here's the horizontal band connected to the lateral pole. So once we get to a point where this ligament is stretched, that actually becomes a fulcrum for any further lateral movement of the condylar head. Now, typically, this is as far as it can go. And what it is doing is that the mandibular condylar head may be trying to jump out of its fossa a little bit. And this is called a side shift, or described by Bennett movement. Don't want to do that a lot, because eventually that's going to stretch or tear these ligaments. But excessive side shift can do that. But it is controlled by, in particular, the horizontal band of the lateral TMJ ligament, but also some some restraining forces in the oblique band as well. So the side shift is actually something that is directly related to this lateral temporomandibular joint ligament as we move to the chewing side, the working side. Okay? So that we don't dislocate the joint.
You said something earlier, so it's the right side that limits the left lateral movement and the left side limits the right lateral movement? Did I interpret that?
The right side creates movement to the left by the pterygoids. The left pterygoids create the working side movement to the right.
But are the pterygoids a muscle or a ligament?
Muscles.
Oh, okay.
We don't have, we didn't mention the pterygoid. Okay. All right, the ligaments try and maintain the integrity of the joint throughout movement.
Regardless of which direction it's going?
Right.
Oh.
I mean, obviously, there's gonna be some stretch on the balancing side, but not to the extent that it is on the working side. As we continue to move in a working movement or a chewing movement away from the occlusion of the dentition. You know, so this would be like, as we're getting too far, we're actually not only risking potential to pull this contour head out of the joint space, we're also disoccluding the maxillary mandibular dentition, potentially, depending upon the size of the occlusive surface. All right, so this joint space is innervated by branches primarily of the trigeminal nerve. The synovial fluids are pretty much controlled sympathetically, because if you remember, sympathetics actually control the vascular dimension by primarily by closing or reducing flow, okay? So if they're more relaxed, there's an increase in flow of fluid into the joint spaces. Okay? But that's autonomic sympathetic. From a sensory perspective, the trigeminal has a couple branches that innervate this whole joint capsule region. These branches come from cranial nerve 5, 3, mandibular division, and these are masseteric branches. These back behind the joint, or what we see over here in the very back of the joint, these are from a portion of the trigeminal nerve mandibular division, or D sub 3, that are auriculotemporal. Okay. Now you notice that the only motor innervation that I gave credit for was that innervating blood vessels, because we don't stimulate ligaments to move. We do monitor their stretch, but we don't cause ligaments to move. Okay? But we need to know if there is excessive stretch on a ligament, hopefully to stop at a point where we do not do damage to the joint space. And that's throughout the body. Or otherwise we can tear the ligament or we can disassociate it from it.
So you said these particular branches of the trigeminal nerve are sensory?
Sensory, general sensory. So for things like pain, stretch, so. All right, let's look at the muscles. We'll be looking these at again, and when we talk about infratemporal fossa. Okay, so we've got here temporalis. We'll see with the temporalis that on the side of the skull there is a superior ridge. And this is called the superior temporal line. And what attaches there is the dense fascia that surrounds the temporalis and holds it together, the deep fascia. okay, that holds this muscle together from the superior temporal line and covers the temporalis. The temporalis arises from this ridge, and this is the inferior temporal line. And will it attach, we can't see it because the masseter is covering it, attaches to a region of the mandible referred to as the coronoid process. So if we look at this on the cadaver, here's your temporalis over here, with still some of the fascia over the top of it, and then here's the masseter. We'll talk about the masseter attachments in a minute. So the temporalis muscle attaches from inferior temporal line to the coronoid process of the mandible. Now it just, here you usually see it illustrated, they don't draw it completely as far as its point of insertion. So completely, it would actually be totally surrounding this coronoid process. Now, the temporalis can do a couple of things. One, no other muscle mastication. The more anterior and middle fibers, as they pull, they are pulling upward. Here, and they are elevating. But these fibers back here are coming in at a right angle, and so they may assist in elevating, but their primary role is to pull the mandible back into its most superior position, retrude the mandible. These retrude, these posterior fibers. Temporalis is a relatively strong muscle, but not as strong as its counterpart, which is the masseter muscle. Let's see how this. Okay, so let's go back here. The masseter muscle has two heads as well. One a very short head. This is its superficial head. And this is its deep head. Now, its primary attachments, its point of origin, is from the zygoma and the zygomatic arch. Its point of insertion is on, one second, its point of insertion is on the outer arm side of the mandible, the ramus, okay? It attaches over the surface of the ramus, onto that surface, all the way down to the angle of the mandible. It does not just attach to the angle, it attaches on the surface of the mandibular ramus.
Now, do both of these muscles pull the mandible up, or does one of them pull it down?
The masseter muscle also raises or elevates the mandible. Okay. The temporalis and masseter are muscles of elevation, or they bring the teeth together, they are muscles of clenching.
Right, so what's the, okay, so.
Both of them. Masseter muscle, talk a little bit about that, and we'll get the infratemporal fossa to describe it, is an interesting muscle. It's probably one of the strongest muscles in the body that can exist in its short space. 600 to 900 pounds per square inch. There's got to be something in there that's allowing it to do that. Okay. All right, so then here's the masseter. Here's its superficial head. Here's its deep head. here's its attachment. So both the temporalis and the masseter elevate the mandible, clench the teeth. The temporalis, in addition to elevating the mandible or clenching the teeth, can pull the mandible posterior, protrude it. It's the only muscle of mastication that can do that. Okay, and then we have two muscles that are deep muscles called pterygoid muscles. And they're called pterygoid muscles because their point of origin is from the sphenoid bone lateral pterygoid plate. Lateral pterygoid plate. And there's one that is more external, okay? And that is the lateral pterygoid, or more lateral. And here we see the lateral pterygoid. Over here is the inferior belly. And it is attaching to this pterygoid fovea that's covered up right now by the capsule. And here is the superior belly. Now the superior belly attaches to the underside of the greater wing of the sphenoid bone. It's called the infratemporal surface of the sphenoid bone. And attaches to the pterygoid fovea. The superior belly, for the most part, arises from this infratemporal surface of the sphenoid bone and attaches to the anterior aspect of the articular disc. The role of that muscle is to see that the disc stays on the condylar head. Okay? Here we see it in a cadaver. You don't really see, here's a little bit of the superior belly. Here's the inferior belly. Okay, and you want the superior belly, one area inside it. Well, how can we show this the best? And so we dissected through the floor of the skull, and here we're looking down on the superior belly. Or head. And here's the disc. So here's that attachment along the front of the disc. Disc is pretty large. Okay? Condylar width medial laterally is about 10 to 12 millimeters. Okay? Anterior posteriorly it's 5 to 8 millimeters. All right, so here's the lateral pterygoid. Bilaterally, it moves the mandible downward and forward, which is we call translation. Okay. Unilaterally, each side moves the mandible to the opposite side. Right moves to left, left moves to right. So that's the chewing, that's chewing. And we have this muscle, medial pterygoid. And the medial pterygoid also attaches to the lateral pterygoid plate, but on the medial side of the lateral pterygoid plate. The lateral pterygoid attaches to the lateral side, this side here, of the lateral pterygoid plate. This is the medial pterygoid. It's attaching to the medial side of the lateral pterygoid plate, and it's going to come down and attach to the angle of the mandible, not like the masseter muscle, more in a sling-like position, coming from a more medial to lateral position, a more anterior to medial position. So this muscle actually moves the mandible similarly to the lateral pterygoid. It moves it bilaterally downward and forward. Ipsilaterally, or one-sided, it moves the mandible to the opposite side. It also has a head. Here's the maxillary tuberosity. And the maxillary tuberosity, the maxillary tuberosity, and it comes down to attach to the angle. Here's a cadaveric representation. Here's medial pterygoid. So here, this actually is the medial pterygoid plate. Medial side of the lateral pterygoid plate is where the medial pterygoid has its point of origin, and then it comes down to the ankle. Okay, and just showing it in this representation. Okay, we'll use this last image again. We talked about it for temporal fossa. So there's a lot of stuff here, okay? Your dentists for the most part see a lot of these patients who come in with so-called temporomandibular related disorders, okay? Either referred from another dentist that knows you have some expertise in it, or from some physician who realizes that this is out of their purview, okay? It is a complicated joint complex, and you have to realize that. And when you're diagnosing temporomandibular joint disease, you have to get all of the data, all of the data. You have to ask the patient a lot of questions, both from the standpoint of what's going on now, has this ever happened again, what type of pain are you receiving, okay? When is it worse? Look at the tooth surfaces and see if it's grinding or missing teeth or malpositioned teeth, okay? Palpate the muscles to see if they are tender when they are just resting, or when they are moving or open or closed. So you have to take a lot of data. It's something you have to be very careful of, also from the standpoint of a litigation, because I'll tell you this, years ago, the insurance carriers used to be more lenient with allowing dentists to do temporomandibular joint evaluation and treatment. And then because of all of the mistreatment that went on, because the dentist didn't realize what was going on in his joint, they eliminated it as a dental code, okay? And unless you can demonstrate that you had excessive training in temporomandibular joint disease, or they would allow an oral maxillofacial surgeon to get involved with it, but not a general dentist, okay? So you have to use this information to be able to determine what's going on in this joint complex. And that's why we just don't call it temporomandibular joint, we call it a gnathostomatic system. Okay. All right, I'll see you this afternoon for GI.